You can see
Yes,
this.
sir.
Okay. So thank you. And over the next 15 minutes, what I'll do is I will talk about the management of relapsed refractory chronic lymphocytic leukemia, primarily based on a few cases that I have. So I'll try to see if there is any evidence of what we should probably do or recommend. They may not be complete right or wrong answers. But as this is the therapeutic landscape of chronic lymphocytic leukemia is really evolving because of such effective medication that have been tested in the last decade or more or so in phase one, phase two, and even phase three trials. So one can go with the comorbidity adapted approach. You can look at a patient who's somebody who's 50 years old, somebody who's 70 years old. A 50-year-old can have severe comorbidities. You may select a therapy that you would not otherwise select for a younger patient. So it's also a comorbidity adaptive approach. And then, of course, the most important, which were already discussed in detail by Dr. Firas about the prognostic factors adaptive approach. One should be able to get, and this has become a standard, to see whether the immunoglobulin heavy chain variable region is mutated or unmutated. This will give you an idea whether you want to treat with chemotherapy or a targeted agent. And of course, deletion 17p or p53 mutation and 11q to some extent also is somewhat higher risk. Then, of course, the fit versus unfit will again go into the comorbidity adaptive approach. And then the decision whether you want to treat with immunotherapy versus target therapy based on all these factors. So let's look at through the process of some clinical cases. I had this 54-year-old known diabetic, type 2 diabetes diagnosed from before. In March 2014, he had a CLL of rise stage 2, with spleen was palpable, white cell count was 131, hemoglobin was relatively okay, and platelets were 219,000. So things were doing well. I kept on observation. The white cell count within the next 6 months or so, to 9 months, jumped to 270,000. So also the lymphocyte doubling time was, as Dr. Firas had mentioned before, doubled within probably 6 months. And he dropped the hemoglobin to less than 10 or 10.5, and platelets were still 129,000. Spleen went up to 5 centimeter below costal margin. Liver was also palpable. Bone marrow was diffuse infiltration, but there was no chromosome abnormality except 13q deletion, which is not a high risk for the information. So in any case, because of overall worsening of the condition and indication that he had gone to at least stage 3 now, so we decided to treat the patient and we gave the patient FCR. I did not have the IGHV mutation available at that time. He went into hematological response quickly, but still spleen was still palpable 2 centimeter, but the CBCD was normal. Now, 3 months later, his hemoglobin was 11.2, platelets were still 60,000. White cell count had come down to 8.5, with majority of them still lymphocytes, and the bone marrow showed diffuse involvement. This patient was referred to me. So in June 2015, WBC again was 29, platelets were low, 37, and hemoglobin had come down a little bit to 11.4, 114. I observed the patient for a little while the patient was back and forth from the referring hospital. The white cell count had gone up to 68. The platelets improved. We initially thought maybe this was chemotherapy effect, but platelets did not go above 74, and actually the hemoglobin dropped to 103 for a male patient, which comes under the definition that may fit him for stage 3. Chromosome again 13q, clinically stable. Generally, he was asymptomatic. So what do you do when a patient is not in complete remission post FCR, hematological parameters slowly worsening? When do you decide to treat with second line, especially for somebody who's asymptomatic, but the hemoglobin has dropped, the platelets have gone down, so indication of therapy is there. What regimen to use, what is the prognosis, chemoimmunotherapy versus BTK, or the B cell receptor inhibitors versus BCL2 inhibitors, or would you take this patient to allogeneic transplant since the patient was young? In any case, let's look at some of the data. There is a Resonate trial showed that 6-year follow-up actually was published, and this showed that targeted therapy did have an advantage over the monoclonal antibody for as far as the progression-free survival was concerned, and even that was sustained in patients who had a high-risk population. So somebody who did not, we have no idea what are the underlying abnormalities one can treat, but also in this case, for relapsed refractory, he did not have any of those high-risk genomic factors except 13q, which is not a high risk. So one can still, I guess, use this because the patient response to FCR or able to maintain a remission in FCR was suboptimal or poor. So even for those, this that just shows that ibrutinib was able to maintain its efficacy in poor risk prognostic factors also. I will not go over the side effects because Dr. Faraz in the previous slide already mentioned most of them. But as the time passes by, most of these side effects or neutropenia or thrombocytopenia or pneumonia actually goes down, except maybe hypertension, which seems to be a bit more than as the time passes by. And one has to be careful about atrial fibrillation, although the incidence does decrease. Some pneumonitis effect is still there. So the conclusion of the RESONATE trial was that the robust and durable efficacy of ibrutinib was well established. An improvement in the outcome was evident in all risk groups. And the clinical and genomic features and the safety analysis established that continuous treatment with ibrutinib can be delivered without any significant side effects to the patient with chronic lymphocytic leukemia and continues to provide benefit for a long term. So case 1 follow-up, I did, so would you consider another chemoimmunotherapy or status of IGHV still not known? I don't know whether that will make a difference at this stage because the patient has progressed beyond chemotherapy. Very effective, one of the most effective chemoimmunotherapy, the FCR at a younger age group. Whether IGHV mutation is still relevant over here, but certainly there was no 17p abnormality. So initial therapy was FCR suboptimal therapy, progressive disease 12 to 18 months. So I started this patient on ibrutinib in 2016. And the last follow-up recently, I saw this patient again. He's currently in complete remission and he has no significant side effects of any atrial fibrillation or uncontrolled hypertension or any GI bleeding or anything. So he's doing very well. He's young. He's back to his work. So would you consider a combination of novel agents if you have an access to more than ibrutinib at this age? Case 2, well, let's look at another case. Suboptimal response to chemoimmunotherapy, relapsed, refractory, when to switch and what to switch to. So this was a 47-year-old female. She had RISE stage 3 or Bendamustine in August 2018. The chromosomes FISH analysis was done, was normal. CD38 was negative. IGHV status was not known. I didn't have an access to that one at that time. The patient, I gave FCR, just like the question that was asked to Dr. Faraz, that if you, although I didn't have chromosomes, but IGHV status was not known. And so I decided to proceed with FCR in this patient. Poor to suboptimal response was seen. Within persistent splenomegaly was there, and the WBC actually increased from up to 200 instead of responding to FCR. So I changed the treatment to ibrutinib, 420 milligrams daily. The patient did achieve hematologic response. Whether I would have gone directly to ibrutinib directly, I guess you can, especially a young patient. But giving, as Dr. Riyad's opinion was to give try a combination chemotherapy, this could have gone the other way also. It was just that the patient did not respond to FCR, so I switched the patient to ibrutinib. So what do you see here? So we have, if you want to use a combination, for example, there is a Clarity study that was ibrutinib plus venetoclax in relapsed refractory setting. Results of the blood-wise TAP study. They used this one, started the ibrutinib and then later on added venetoclax to avoid also ramp up to avoid tumor lysis. And then later on, after 12 months, they looked at the MRD negativity in the peripheral blood and the bone marrow, both at 6 and 12 months, and then decided to continue ibrutinib plus venetoclax or ibrutinib. There was for patients who had beyond clinical response for less than 20 or equal to 24 months for venetoclax. So the primary endpoint was eradication of MRD in blood and bone marrow after 12 months of combined therapy. Key secondary endpoints were, again, they were looking at the MRD eradication and response by the IWCL criteria, and the MRD negative, again, of at least 1 per 10,000, which is like less than or equal to less than 0.01 or MRD4. After 6 months in this study, they reported the first one, 6 months combined therapy, undetectable MRD 39% in peripheral blood, 24% bone marrow. So this kind of approach, although I'm not arguing right now, but for the case that I used was ibrutinib. But if somebody is young, you can take an opinion of going for a combination therapy if you think you want to get an MRD negative and stop therapy. So it will not be a 6 months, but can be, which the patient did not respond to, fail. One can go for another round for relapsed refractory setting. Again, this is like almost immediately after chemotherapy, to whether you can get an MRD negativity and then stop the therapy. So after 12 months of this therapy in this trial, all patients had responded by the criteria. Complete remission was seen in 58%, and 87% out of them had no morphological evidence of CL in the bone marrow biopsy. MRD4 was achieved in large number of patients. The one who had complete remission, 58% patients in peripheral blood and 41% the bone marrow. Bone marrow obviously have a higher tendency to give detectability, but the concordance rate is almost very similar. So most of the people tend to do peripheral blood now. Continuous improvements in the depth of MRD reduction with 41% in MRD4 and 29% having undetectable. That means MRD5 less than 0.001. So efficacy was based on the data log on 2nd August 2019, was again presented in an IWCLL meeting in 2019. That was before COVID. 49 patients have reached 14 months. So that continued to improve. Peripheral blood undetectable MRD was 57%, and the bone marrow was rose up to 39%. All patients were progression free in life. So combination really do work. I think it should be limited to the one that you think who are going to benefit, especially the younger patients that you don't want to continue on therapy for the purpose to avoid long-term side effects that some of them are still maybe not fully known or understood. So case 2, the refractory CLL received 2 cycles of CRs, still this disease. I changed the treatment to ibrutinib at that time. So in a 2-year follow-up, patient still excellent response, achieved and maintains a CR and tolerating the therapies very well so far. Looking back, I may have used, but since the patient now has achieved a CR, I may monitor MRD on this patient, and then I will probably make a decision. Looking back, there was a possibility if this information was more known to me in 3 years ago, I may have used a combination for a short time period. Relapsed refractory CLL. Let's look at another case before we go to some other data. CLL, SLL, long time ago, almost 20 years ago, nasopharyngeal mass with bone marrow positivity. At that time, FCR was available. We used to give FCR to all our patients with CLL, SLL. Patient achieved excellent CR for 12 years, as was mentioned by one of the comments from our panel, that they can go into a CR for 10, 12 years. So in 2012, he presented with progressive disease, again with nasopharyngeal mass, and it was resected to some extent, and that showed again CLL/SLL with a small focal of Richter's transformation. So it was a small, even if it is a small focal, you have to take care of it because this could be a transformation again. So I offered him as R-CHOP with involved field radiation therapy, as this was the only site of the Richter's transformation. I thought I'll give him more chemo and involved field, but he refused. He got 4 cycles, then he says, I don't want involved field radiation therapy. I offered him 2 more cycles of R-CHOP, he refused. Anyway, so this was it. So he went into remission for some time. In 2015, he presented again, and this time with left facial palsy, left arm mastoid mass, PET positive, bone marrow positive. For again, workup was done. Chromosome was 12 plus and 13 Q abnormality along with anemia and thrombocytopenia. He had a progressive disease in February 2015. So I started my ibrutinib that was available at the time. He achieved a CR and PET was negative. So no specific side effects from ibrutinib, no hypertension, no arrhythmia. So I decided to continue him on ibrutinib. He was seen periodically. He had very mild normocytic normochromic anemia. I did try to work it up, especially to make sure that he's not having some GI bleed. His Combs is negative, reticulocyte vitamin B12 folate, everything was normal. Stool for occult blood, there was no occult blood in the stool. So that means some normocytic normochromic still can happen. The patient remained asymptomatic. He had low iron but normal ferritin. Possible mild on and off GI blood loss. Endoscopy was done, that was okay. His bone marrow was done. There was no MDS. We just wanted to make sure that we're not missing or something since he's an elderly age group, not entirely elderly, but was in the sixth decade. So hemoglobin remained stable, and the CT and PET scan was done, and he was found to be in complete remission on ibrutinib. But later on, as a follow-up PET, we did because he had some complaints of coughing and other things. So we found that he had at that time mild FD avidity. Is not the best test to do for CLL, but there was no evidence to suggest a Richter's transformation. So he was thought to be still in an excellent remission and continued on ibrutinib. But at the same time, he presented again with coughing, and we did some X-rays and CT, and was found to have this patient was found to have interstitial pneumonitis. He also underwent a biopsy. And this was consistent with interstitial pneumonitis, which can happen in a small number of patients on ibrutinib. And so this what the question would be: what would you consider changing therapy at this stage, and consider venetoclax, or do you think we can still have a treatment-free remission if the patient responds to some other therapy in relapsed refractory settings? Let's look at the MURANO was used also. Also in relapsed refractory setting, the venetoclax rituximab showed a superior as compared to bendamustine rituximab chemoimmunotherapy. The overall survival was better, and the side effects were tolerable in both. I think the neutropenia was almost maybe slightly higher, but it was almost the same. Otherwise, some of the side effects were actually better in venetoclax rituximab as compared to bendamustine. Pneumonias can happen in both, but pneumonitis is something that we saw with the ibrutinib. And of course, the hemolysis can be there. Anyway, so what I did was no significant disease progression other places, but interstitial pneumonitis was there. So the ibrutinib was discontinued no further, and patient was started on venetoclax, and he responded to it and remains without disease progression. What about a combination of novel agents? Would you like to do a combination at this stage? Can instead of venetoclax, can BTK therapy still be effective in some patients who fail or resistant to venetoclax? Not specifically for this case, but in other cases. So this was a combination of phase 2 study, just recently published a few months ago, with obinutuzumab plus ibrutinib plus venetoclax for treatment naive and relapsed refractory setting. If you look at it, the PR is almost similar, but CRI, actually, if you look at it, end of treatment in relapsed refractory setting, an excellent response. So that clearly shows that combination therapy in relapsed refractory setting can work very well. When you look at the same combination and look at the probability of progression-free survival for relapsed refractory or treatment naive cohort, it is seems to be an excellent outcome, even if the follow-up is not too prolonged over here. Can BTK therapy be effective if patients fail? If you had put this patient on venetoclax instead of ibrutinib at that time, and he somehow developed, could you use ibrutinib or other BTK therapy that's available to you? This one was recently again published in Blood 2020. Again, the progression-free survival and overall survival seems to be is okay for the ibrutinib. So these patients do respond. Looks like, especially for patients who had used venetoclax for more or less than 24 months, there seems to be the efficacy seems to be is very good. So if you look at, so there is always a chance that the BTK therapy can be used even if the patients have failed another advanced therapy of like venetoclax. at certain time points. So we have a lot of medications now that are accessible that we can give benefit to the patient and reassure the patient that these medications can be switched and they can still remain in remission for a long period of time. So in summary, targeted therapies may markedly improve response and survival of relapsed refractory patients with CLL, including those with high risk. Does immunotherapy no longer have a role or limited role? It's not entirely true, but still you have to look at the comorbidities. There is always a possibility that some of these patients may be old or may have mutated IGHV and no long term, but they relapsed. But there is a lot of comorbid conditions that you think may not be somebody with severe hypertension or uncontrolled atrial fibrillation. There's always a chance that you can use, based on your assessment of the patient, some sort of chemoimmunotherapy can still be there. So it does not mean that it does not have any role in the relapse setting. But generally, the relapse setting is more amenable and more responsive to, apparently from all the studies published, to the targeted therapy. The challenge now is how best to sequence the treatments, and as the more data comes out, we have single agents, we have multiple combined agents. Even relapsed refractory setting, it seems there is always a chance that you can use it for a limited time period of a few years, and then if they achieve MRD negative, you can follow these patients. And there are numerous ongoing trials, and also another challenge is to manage side effects, and continuation or change of therapy is also challenging. I think that's the last one. Thank you very much. I'll stop here. If you have any questions, I'm ready to take it. There's one question from Dr. Syed Zaidi to everyone. As specific mutations develop over time on ibrutinib or venetoclax, leading to progression after response without transformation, that will require switching to effective agents for the given mutation. Should we actively follow for those mutations after losing response? I'll put this question to the group. Dr. Firas, Dr. Riyad, this question from Dr. Zaidi.
So the
question is, would you dynamically follow these patients and continue to follow these patients to see if they have developed any mutations over time?
No. And the reason is this mutation, like the ibrutinib mutation, it's called C481S. Okay, this is the resistant mutation that happens while a patient is on ibrutinib, and it usually doesn't happen without progression. So once your patient progress, they developed resistance to ibrutinib, whether it is from the mutation or not. This is a different story. You can check, but there is no indication at all to follow it and repeat testing at all.
Okay. Firas, do you have any comment on?
Yeah, so definitely I agree with Riyad. I mean, the indication for mutation is after failure of targeted therapy, whether it's ibrutinib or venetoclax, and this is a very big field actually. There are a lot of mutations that has been discovered. However, it shall be done after failure of treatment. Thank you.
Okay. So another question, interesting question actually, from Dr. Saud Al-Haili. He wants to know, is there any role of maintenance rituximab after FCR? So to Firas and Riyad, let's say if the patient responds to FCR in the first line therapy, would you, is there any role of maintenance rituximab? Any comment from the panel?
Extrapolation from the low-grade lymphoma data, like follicular, marginal zone, mental. So some people would do rituximab maintenance if the patient post-FCR is not in complete remission. Okay, but this is not backed up by phase 3 trials. This is, maybe a trick by physicians because the patient is not in complete remission after FCR.
Okay. Firas, you have any comment on this?
I have no additional comment, but I see Dr. Zaidi is raising his hand.
Okay.
He can
I don't know whether he can come on the speaker. Is it possible to allow Dr. Zaidi to? Yes, Zia, do you have any?
Yeah, Assalamu alaikum to all. First thing, thank you for responding. However, maybe I was not clear or was not clearly understood.
Yeah, I thought you were asking about
responded.
17p and p53 mutations also, I guess.
No, no. The PCLSG and all those very sophisticated mutations, which I'm talking of a scenario when you start either ibrutinib or obinutuzumab with rituximab, whatever. They respond initially, and then you lose response. Then you even go behind an enlarged lymph node, and it is not transformed. So you are this much you are sure that it is not transformed, but it is kind of losing response or progressing CLL. So shall we go? And it is, to me, still cost effective to know which mutations we are trying to address, or shall we go by our own personal liking or intuitions that which one to shift to switch to? I mean, some are specifically resistant to ibrutinib group, others are
okay, so you mean these patients have developed, you think, a mutation without being exposed to the BTK therapies so far, or the B-cell receptor therapies?
No, on one of the therapies.
Okay,
both
so all
situations.
Okay, so yeah, that's what Dr. Riyad was saying, that I would do the mutation not as a routine, but if the patient progresses, only then.
This is what
is that correct, Riyad? That was your point?
Yeah, I mean, there is no indication to do the mutation just to follow up the patient, but and it's very well known that these mutations don't happen unless the patient is on BTK or BCL2. There are BCL2 mutations as well reported, but they don't happen like BCL2 mutation don't happen if the patient is on ibrutinib, and vice versa. The C481S mutation doesn't happen if the patient is on venetoclax. So a resistant mutation to ibrutinib happens when the patient is on venetoclax. They don't.
There are many more mutations which do happen on both therapies.
Correct.
So when they happen, do we switch without knowing which mutation is causing a loss of response, and we should go for the most appropriate one? This is my question, not in routine. When you are losing response on ibrutinib or on obinutuzumab, they have specific profile of mutations, not only one mutation. Which
the question is. So I guess, I mean, ideally, yes, you should do the mutations and then switch accordingly. But unfortunately, I mean, many centers, they don't have the mutational analysis available.
That's what I just
think
wanted
the mutations
to make
are rare.
point.
That's number one.
That we should, on Saudi platform somewhere, we should try to develop a profile analysis of those NGS panels. We have developed our own at King Fahd Medical City, although we are yet having some financial difficulties to apply it. However, we will be doing so. A big panel of mutations we will be looking for in such scenarios.
Yeah, I think the incidence of these mutations actually is still very low. So I think the question would be, is it beneficial? I think as a 10%, if the patient is on some of these BTK inhibitors or B-cell receptor inhibitors or venetoclax, B-cell2 inhibitors, if they do have a disease progression while on this one, if it's easily available, not all, I mean, a lot of people still do Sanger sequencing, whether that will be picked up or whether you go for NGS or to pick up any mutation and then make a decision. It's difficult.
We are going ahead, alhamdulillah, in Saudi Arabia for sequencing stuff. So these are expensive therapies. Trying another drug which will not be effective without, if at all available, without doing it, I think it will not be the optimal thing, right?
I think that's okay. You have to understand that it has to be cost effective doing it also, because even if you look at the data from CML where the incidence of mutations is much more, it is still, when they progress, it's still less than 10%. And they say that out of those 10%, it is only 10% that you really are the one that you make a decision. So I have a feeling that, as Riyad says, that number one is really the one that you would be able to make a decision and if you have somebody
Yes.
progression, then to do this
more
test
informed decision. Yeah, we have to make more informed decision. This is what.
So
Okay,
let me
thank
get
you so
just
much.
one. Thank you so much. There was just last question. This was from Saud. He asked if patient failed ibrutinib, would you try other BTK inhibitors other than ibrutinib? There are more available, I think, in the.
I will, Dr. Naeem, I will address this in the case discussions.
The case, okay, that's a good point. So for South, I think maybe the case this can be raised in the case discussions. So what I'll do is now is it's almost 12:05, so it's time for a break. We'll take a break for 10 minutes.
Dr. Naeem, I don't know what the group think, but shall we proceed? I mean, rather than
I'm okay with it. I thought maybe if people or the audience wants to take like 5 minutes, we are okay to proceed if the administrators.
May I suggest if people want to break, they can raise their hand using the.
If they can, people can put a message over there if they
message.
want a break
Yeah.
for 5-10 minutes or.
Otherwise, I think we can proceed. What do you think, Riyad?
I'm okay either way. I mean, proceeding is fine.
Let's see if there's anything comes on the message.
10 minutes break.
5. Okay, so 2 minutes break.
Okay, so we'll start 12:15 exactly. I think Nesma, you'll take care of the case discussion thing. So we will meet at 12:15. So the administrators will divide the group accordingly. Is that correct?
Yes, doctor. We will be requested to participate in a poll survey first,
Okay.
and then we will divide the audience
Okay.
to 2 groups.
So we will start exactly at 12:15. Is that okay? Or we'll
Okay,
do a poll first. You want to do the poll first?
Yes.
Okay, so here's the first slide on the poll. Please, can you vote?
Yes.
All the audience, if they can vote. This looks like they've gone for a break, 0 to 27. Maybe you can put this question again. If there's no voting is less, you can put this again before we start the next session.
No, you can keep it. I see people are voting.
Okay.